Good afternoon, everyone, and welcome to the Leadership Development Group's webinar entitled How Health Ecosystem Leaders Leverage Social Determinants to Envision the Future of Health, being presented today by Drew Harris and Rickie Brawer. My name is Lisa Clark, and I am the Director of Operations and Coaching at the Leadership Development Group. Just a few quick notes before we get started. Please note that all attendees are automatically on mute for the duration of the webinar. We will be taking questions. Please feel free to submit your queries through the questions box on your GoToWebinar control panel, and they will be presented to our panelists at the appropriate time. This webinar is being recorded, and we will provide a link to the recording to all attendees. We appreciate your attendance and hope that you find this webinar valuable. I will now turn this over to my colleague, Tara Sattler, who is the Director of Client Solutions at the Leadership Development Group, for a brief introduction. Tara?
Thank you. Thanks, Lisa, and good afternoon, everyone. I'm delighted to welcome you to the first webinar in our year-long series featuring our Health Ecosystem Leadership Model, or HELM. Today's inaugural webinar, How Health Ecosystem Leaders Leverage Social Determinants to Envision the Future of Health, is being presented by two of our esteemed faculty members, Dr. Drew Harris and Dr. Rickie Brawer, both of Thomas Jefferson University. Next slide, please. But first, a little bit about TLD Group. Next slide, please. Our mission: developing leaders and teams to execute strategy within their organization, within their sector, and across the health ecosystem. Our vision: transforming the health industry through its greatest asset, its people, through our innovative talent development solutions. And our values: innovation, mindfulness, passion, agility, curiosity, and teamwork to create impact. Next slide, please. As many of you know, TLD Group is a global talent development consulting firm for leaders, teams, and organizations with an exclusive focus across the health industry, including providers, payers, and pharmaceutical companies. We work with organizations to align their talent to business strategies through our 4 service lines: executive and physician coaching, consulting, leadership development programs, and speaking engagement. Yeah. Next slide, please. All right, I'll give you 2 minutes. I'm now going to hand the mic over to TLD Group's founder and CEO, Tracy Duberman, to tell you a little bit about our HELM model, the research behind it, and our inaugural webinar series.
Thank you so much, Tara.
Tracy?
Yeah, thank you, Tara. Appreciate it. We at TLD Group have had the distinct pleasure of working with some of the brightest talent in our industry, leaders who are clearly making a difference in the work they do to provide high quality care to those in need while working on solutions to enhance health and wellness. However, no one can argue that the U.S. health industry is in a great spot. It's facing ever-growing issues and challenges. The great majority of them are too complex and wide-ranging for any one sector to solve independently. Our Health Ecosystem Leadership Model, otherwise known as HELM, provides a framework for how leaders can generate cross-sector solutions to the health industry's most pressing needs. Developed from our research, interviews with over 25 industry executives across the health industry, our model is geared around the following 4 capabilities: envisioning the future, aligning stakeholders, managing boundaries and obstacles, and acting and learning. I'm thrilled to add that our HELM research and model culminated in a book that I had the pleasure of co-writing with TLD Group's extraordinary advisory board chair, Dr. Bob Sachs, and is titled From Competition to Collaboration: How Leaders Cultivate Cross-Sector Partnerships to Drive Value and Transform Health. Our book, which is being published by Health Administration Press, is due to come out this October. Which brings us to today and the kickoff of our HELM webinar series. This series will consist of 4 webinars, corresponding to each of the 4 capabilities of our HELM model and will be facilitated by our TLD group faculty members. Today's presentation addresses the HELM concept of envisioning the future and is aptly titled, How Health Ecosystem Leaders Leverage Social Determinants to Envision the Future of Health. With that said, it's my sincere pleasure to introduce you to our esteemed speakers, Dr. Drew Harris and Dr. Rickie Brawer, both of Thomas Jefferson University. Dr. Harris is a researcher, author, consultant, and speaker in the fast-growing discipline of population health. His current positions include Director of Scholarly Inquiry and Health Policy at the Sidney Kimmel Medical College, Assistant Professor of Jefferson College of Population Health. He is also an active health advocate. He publishes frequently in the Philadelphia Inquirer, the Wall Street Journal, and other publications on topical health policy issues. Dr. Harris received his DPM at the Pennsylvania College of Podiatric Medicine, an MPH at the University of Medicine and Dentistry of New Jersey, and his BS from Wilkes University. Dr. Rickie Brawer is a public health practitioner, educator, and researcher. Currently, she is an assistant professor, Department of Family and Community Medicine at the Sidney Kimmel Medical College, co-director for the Center for Urban Health, Thomas Jefferson University Hospitals, co-director of Scholarly Inquiry, Population Health Research at Sidney Kimmel Medical College, and an adjunct faculty of the College of Population Health. Dr. Brawer received her MPH and PhD from Temple University and her BS from the University of Connecticut. And now it is my pleasure to turn the presentation over to Drs. Harris and Brawer.
Well, good afternoon and thank you. It's a pleasure to be here today. And so let's talk a little bit about the aims of today's webinar. We're going to examine how the movement from a volume to value-based care is stimulating really interesting collaborative opportunities to address the social determinants of health. We'll be discussing and describing some of the resources that you're going to need for reliable and robust community health data, and identify some of those evidence-based practices for addressing community health issues, and provide you with some examples of community collaboratives that are inclusive of those impacted by health disparities and equity. And hopefully at the end of our session today, you will have a new appreciation for the whole new care delivery paradigm and how it requires a broader understanding of the community level health determinants, how you can use a community health needs assessment to lead to a better value-based care program, and how you really must learn to foster and support community collaborations. So first, Lisa is going to ask us a polling question for all of you to answer.
Okay, so we are up to our first polling question, and here we go. Have you ever participated in a community health assessment? So if you'll take the time right now to register your answer, the choices are never, once, occasionally, frequently, and my primary responsibility. So I'll give you a few seconds, to vote. Okay. A few more seconds and I'm about to close it. All right. So the answer basically to the question, have you ever participated in a community health assessment? 70% have never participated, 15% have participated once, 11% have participated occasionally, and 4% have said frequently. There is no one who said that it was their primary responsibility.
Well, that's very interesting and certainly appropriate for what we're going to be presenting today. So thank you for responding to the poll. So I'm a big believer in telling stories. You hear a lot from me and when I give my talks. And in this case, we actually wrote a special story for today's webinar. And I just want you to imagine that there is a nurse, Mary Smith is her name. She's the ED nurse supervisor. And she notes that JJ, who's a 10-year-old boy, a son of a hospital employee, is presented to the emergency department for the 4th time in 6 months for treatment of exacerbations of his asthma. And she also notes that he was hospitalized twice in the past year, and that his mom, who's actually a clerk in that unit, has been late in or missed work on a regular basis. This mom has mentioned that the child is also struggling in school. And so Ms. Smith is looking specifically at that patient, but is now beginning to think about what are some of the other issues and other people who suffer in similar ways within the community they serve. So she's asked for a more detailed analysis for the asthma diagnosis code and finds that asthma admissions are quite high for patients from a particular neighborhood, let's call it the northern neighborhood of the city. And so that's the story that I want you to have in the back of your mind as we go through today's talk. And we're going to revisit the story later on. And hopefully when you hear the story, you can appreciate people in similar situations that you might have some of the same experiences with in your setting. So here is two maps that can show us that the average life expectancy between communities, neighborhoods within the same city can vary by as much as 25 years. And they just are just a few miles apart. And we only cite here New Orleans and Philadelphia, but these maps are available for many different communities. And it's really significant because it's been said that your zip code can actually be more important than your genetic code when it comes to health outcomes. Two people with similar genes, the same familial risk factors, can have vastly different outcomes based on where they're born and raised. These maps are just those two examples of that. And now imagine that your practice or your health system covers all of these communities. So it's in your interest to understand why these differences exist and why you should do something about it. This is especially true if you've taken on some form of risk within your practice to address the health outcomes of a population. Now, I used to tell my patients that if you wanted to live a long and healthy life, there are 4 things you needed to do. First, you had to pick the right parents. And then you had to pick the right behaviors. Then you had to pick the right place to live. And finally, and least importantly, is picking the right doctor. And these are really the key determinants of health: genetics, individual behavior, the social environment, as well as the physical environment and our medical care. These are what determines how long a life we're going to live and the quality of that life. And when the analysis is done and we break it down by what are the relative contributions of these factors, we find that clinical care comes in this particular pie chart as 14%, but it's been estimated as low as 10%, as high as 20%, having an impact on our health outcomes. Yet when we look at the amount of money we spend, 88% of all that we spend on healthcare on health overall goes to actual medical care, the delivery of health care itself, as opposed to things like our behaviors. So we're putting a lot of money into an area that only is going to yield a limited return. Instead, we have to broaden where we put our resources to address some of those broader issues. Now, maybe there's not a lot we can do about genetics at the moment, but there certainly are things that we can do to help people live healthier lives and address the environment that they live in. Now, the Institute for Healthcare Improvement has developed this model of the determinants of health, and you can see that the ultimate goal is to create a state of well-being. And we do this by treating disease and injury to improve health and function and reduce mortality. Now, all of this is mediated by the medical care we receive. But as I said, medical care only accounts for between 10 and 20% of what makes us healthy. We need to look upstream at the individual factors such as behavior, genetics, and resilience, and even further upstream at the social, economic, and physical environment that people live in. These upstream factors are mediated by prevention and health promotion activities. Then there's equity. Now, it's widely known that medical care in our society is not equitably distributed. If you have insurance or access to the money to pay a high deductible, then you can get care. If not, you're in trouble. But we don't necessarily think about how some people in communities don't have access to the resources necessary to prevent disease and avoid a harmful environment. Factors like green spaces, good education, well-stocked groceries and supermarkets, and safe streets and homes. These are important factors that can determine the health of individuals. And as a result, health outcomes can vary quite differently depending on where you live and what population you belong to. Tom Frieden and his colleagues developed the health impact pyramid to look at these determinants and figure out what buttons need to be pushed in order to change it. The determinants are going to tell us there are things that we can do, but what's going to have the greatest impact? Where can you put the most effort? Now, the pyramid is organized in a way at the top where things that require the most individual effort are, such as counseling and education. You can put a lot of effort into trying to live a healthier lifestyle. But then there are also clinical interventions, long-lasting protective interventions like vaccinations, and finally changing the decision-making context and addressing the social economic factors. They believe, and I believe, that these are the things that are going to have the greatest impact on the overall health of the population. These are the default factors. If we can change the environment that people live in so they can just be healthier, then we don't have to expect as much of them in terms of trying to improve their own health. And so we should be focusing in on some of those things at the bottom of this pyramid to really address health outcomes. And let me just give you an example. At the top of the pyramid, counseling and education, we could use Weight Watchers as an example. And I believe their data shows that 40% of their patients, their clients, achieve their goal and maintain it. If you go down to clinical interventions, we can do gastric bypass to address obesity. It's a radical procedure, but it is effective, but expensive and not without risks. But maybe we should be promoting a long-lasting protective intervention like sports, or changing the context in which people make decisions, such as food policies, or getting trans fats out of the food would be making people healthier. And then finally, we can develop economic programs so that people can have the quality of life that they need so that they will be healthier as a result. And again, this is going to have the greatest population impact, according to Frieden and colleagues. Now, the triple aim, all of you may be familiar with this, the idea that the job or the goal of a good, well-functioning healthcare system is to improve the health of a population, to increase and improve the experience of care, and to reduce the per capita costs. That's been expanded to include clinician satisfaction, essentially recognizing that a happy doctor, a happy nurse makes for better health outcomes. And it's also been suggested that we add a fifth aim, family caregiver satisfaction, let's call that the quintuple aim. And that is a recognition that a family caregiver is quite important to the outcomes of the health of that individual patient. And if any of you are clinicians, you know how much of a stress taking care of a very sick relative or family friend can be. I'd like to add a sixth aim. Let's call it the sextuple aim. So I felt we really needed this, community satisfaction. Health systems, hospitals, and providers must recognize the important role that the community plays in the health outcomes of their patients. A strong relationship with the community helps healthcare providers achieve their goals. A relationship built on trust is absolutely vital for overall health outcomes. And the community can and should be a partner with the healthcare institutions that cover that particular community. So, why is all this important? Why should hospital executives, why should people in private practice worry about these things that are so unrelated to what's been taught in a medical school or a nursing school? And we need to recognize we're moving from a volume to value-based care approach. No more are we going to be paid a fee for service for an individual care, the individual procedure or diagnostic code or treatment. Instead, we're going to be paid for the outcomes of those activities. And rightly, that's actually a move in the right direction, because before, maybe the incentive wasn't there to try to prevent people from getting sick, but the incentive was focused on getting them well. But again, looking upstream, we need to focus on activities that will help people become healthier. So step by step, providers are taking on more risk for the care of their patients, working more collaboratively to coordinate care, and promoting population health to ensure every factor that influences patient health outcomes is addressed. This requires a new skill set, and community health assessment is a key part of that. Every 3 years, all nonprofit hospitals are required to conduct a community health needs assessment, or CHNA. Many for-profit hospitals are also doing them. They must assess the health needs of their primary service area, create a plan to address those needs, and then assess the impact or evaluate the impact of their interventions. This activity is very similar to what's needed for an effective value-based care program. So I propose that we link these activities. The goals of these activities are pretty much the same. We want to be able to provide a broad insight into community needs. We need to be able to build coalitions to address those issues and to identify and address those issues. We need to work with local public health agencies. And I also believe that for a nonprofit hospital that this activity could actually be an opportunity for charitable giving to the hospital. Not everyone wants to build a new building with fancy technology. Instead, they want to actually focus on improving the health of the community. I believe that the movement towards value-based care means that we have to do this on an ongoing basis as opposed to every 3 years as the CHNA requirement works. And finally, it's an opportunity to leverage that important position that every hospital plays in the community. We need to remember that hospitals are more than just healthcare institutions. They're also economic engines, especially for rural communities. The hospital may be the largest employer, certainly the place with the highest paying jobs, and becomes a vital asset to that community. So everyone should be working together to ensure that the community is healthy and that the hospital has an important role to play throughout that community, not just in the delivery of medical care. So with that, I'm going to hand it back to Lisa for polling question number 2.
Okay. So the next polling question is, how prepared are you to address social determinants of health in your community or your client's community? And the choices are not at all, a bit, getting close, we're ready to take this on, we're all over this. So I'll give you all a few more seconds to register your responses.
So are we taking bets to see what the answers are going to be? I don't know.
All right. Still waiting for a few more people to respond.
You're like a Family Feud survey says, right?
Exactly. All right, I'm going to close the poll now. And it seems that the response that got the most votes was a bit. We're a bit prepared at 41%. 27% are not at all prepared. 14% are either getting close or they're ready to take it on. And 5% say that they're all over this. So,
okay. I think, I don't know, Rickie could certainly respond here, but I believe that's consistent with what we felt was going to happen here where people are. I think folks are already beginning this journey and moving in the right direction, which is why you're coming to webinars like this to really begin to understand how to do this, how to address these issues. And so with that, I'd like to hand it off to my colleague, Dr. Brawer, who will give you more of the specifics on how to do community health assessment and how to build the coalition necessary to address those needs.
Yeah, good morning, everyone. So building on what Drew has shared about social determinants of health, how does this play out for the hospital in the future? And what the American Hospital Association has said is that hospitals in the future will also represent health and prevention, and they're going to be at the forefront as payment systems change. To keep people healthy and out of the hospital, social determinants of health will need to be addressed, not just clinical care. So what this diagram represents is that currently organizations who receive federal funding have to conduct community needs assessments on an ongoing basis. However, most of these needs assessments don't occur in the same timeline. So for instance, health departments have to do it every 5 years. Hospitals have to do it every 3 years. And as a result, we're not on the same page. And what we're hoping to do is eventually create a unified approach to doing needs assessments where we actually we're coordinated across institutions, and what we do is more aligned and unified so that we're able to improve health outcomes and measure our impact together. So I think most of us, know about the patient-centered medical home model, which basically puts the patient at the center, and we consider things like a whole person orientation. But what the Prevention Institute is suggesting is that It's great to have a medical home and a patient-centered medical home, but what we really need to do is bridge what we do in the clinic to what happens in the community. Community-centered health homes do that. They take that bridge between health services and community prevention. So we need to address health risk factors that exist beyond our clinical walls if we're really going to make a difference in the overall health of a population. So how do we do multi-sectoral needs assessments that bridge this clinic to community? Well, Kanya and Kramer have suggested the collective impact model. Now, I need to tell you that coalitions have existed a long time. They were part of the Healthy Community Initiatives. And I think the collective impact model really builds on what we have learned since the 1990s in terms of how do coalitions work, what makes them work better. So these are, I think, I like the name collective impact more than sort of a coalition. It sort of says what we do, but these are the 5 major components of the model. Common agenda, you know, we need a common vision for change that includes common understanding of a problem and a joint approach to actually solving that problem with agreed upon actions. We need a way to measure, and that measurement has to be shared. In order to evaluate our effectiveness, all participating organizations agree on the way success will be measured and reported, and we'll have common indicators, and we will use what we learn as part of improving our efforts. We also need mutually reinforcing activities. And this is diverse stakeholders need to coordinate our activities and our actions so that we do these things together and we mutually support each other and leverage our resources. Continuous communication says that all stakeholders should engage in frequent and structured communication to build trust and assure mutual objectives and create common motivation. And most importantly, and I don't think I can stress this enough, we need what if you want to call it an anchor institution, you want to call it a backbone institution, we need a neutral body who can bring everyone together, where staff are actually funded to support and guide the initiatives and the vision and the strategies. And they help support and align activities, and they build public will, they advance policy and systems change, and they secure and help mobilize resources. These backbone organizations may also be responsible for data sharing agreements. So those are like the major components of the collective impact model. The collective impact model provides the framework also for, if you want to call them accountable care communities, you want to call them accountable communities of health, accountable health communities, coordinated care organizations, multiple names, they all kind of mean the same thing. Accountable health initiatives recognize that there's shared responsibility for the health of the community or patient population across multiple sectors. These efforts bridge clinical and community-based organizations and offer an integrated approach that spans healthcare, social determinants of health, and promote equity. Similar to the collective model, they have a centralized infrastructure, a common agenda. They are multi-sectoral. In communication and continuous communication is key. They have shared measurement systems, and community engagement in this is key. You have to make sure that you have the right stakeholders and all the people who are really interested in solving this community issue. So, for instance, the California Accountable Communities for Health Initiative, better known as CACHI, it was found to be successful. They found that to be successful, you need effective decision making. You need to have accountable stakeholders, and the community has to have fiscal responsibility and fiduciary responsibility. You need input from stakeholders. You need joint understanding of the community needs and assets. You need a common language. A lot of times you get these stakeholders together and you've got architects and you have business people and you have finance people and you got health people. And guess what? We all speak different languages. So we really need to be able to understand what each other are talking about and come up with a common language. And most importantly, we need trust. And I like to say that trust occurs in communities at the speed of trust. Okay. I should change occurs in the communities at the speed of trust. Sorry about that. So another way of thinking about this, Fran Butterfoss and Keegler have been really at the forefront of the idea of community coalition building. And what you see in this model is, again, this idea of a lead agency or convener, stakeholders or who's part of the coalition, what processes are in place that support the coalition, do you have staffing, do you have funding, and what structure are you using? So one of the things that I find really frustrating in the years that I've been doing this is if you don't figure out how you're going to make decisions as a group, nothing much happens. So one of the things you really want to do up front is really get those structures in place. And the model's basically saying that as we engage members, we pool our resources, we build synergy. We're able to do more together than we could by ourselves. Part of that is doing an assessment and planning, doing implementation strategies together, and that's really what's going to drive community change and overall health outcomes. And most importantly, one of the things we need to think about for our members as we do this is the benefits of joining this have to outweigh the costs for organizations in doing this. So we need tools. And we need to understand, how do you engage the community? How do you prioritize health problems? How do we set goals and objectives, and how do we make them measurable? Where do we find evidence-based practices? Do we just decide what we're going to do, or do we actually look at what others have done and learn from that? How do we create an evaluation plan? And do we have the resources that we need? One of the things I think that's very frustrating to communities is you go in, you do an assessment, and then there's no resources to actually implement the plan and sustain it over time. So that's a really important consideration as you begin to choose interventions. So now we're going to get into a bunch of resources that are available to help you through this process. And the first one I'm going to talk about is the Community Toolbox. And then basically, this is a how-to manual. If you've never done a community assessment, you've never brought people together in a coalition, this is a great place to go to get information about exactly how to do this. There are actually slide presentations, there are forms that they developed, and it's a really useful tool to get you started. So one of the first things these coalitions are going to do, and I will say this is kind of the mantra for public health people, you're always asking, but why? And you're going to ask, but why, until you get to the root cause of what the health issue is. And I think you saw that with Drew's presentation is, but why is this occurring? But why is this happening? And it turns out that these can be, maybe it's transportation. What are the challenges that people face? Maybe people can't afford the drugs. And those are the kinds of things we need to be able to understand. It's not just that they're not taking them, but why aren't they taking them? So it's important to ask questions as part of this assessment. We need to know, what do we need to know? What do we need to find out? So one of the things you want to think about is, what is the problem? What's causing it? To what extent is it occurring? Is it a problem for some people, but not for others? And why is that? Do we have resources available that we can use to even address the problem? Is it a problem in some geographies and not in others? So you sort of see that in the zip code maps, why is this different? Why do these differences exist? Has it always been a problem? Is it a recent problem? And how are other people actually addressing this problem? So that's all the information we need to find, and what's been effective. So, and I think also important is, how do we set priorities? Can these things be solved in a reasonable amount of time with a reasonable amount of resources? So this is basic steps in a community health needs assessment. You're basically going to conduct the assessment. You will identify the major health issues. You will set goals and objectives with your community partners. Okay. You will develop an intervention or adapt one, again, with your community partners. You will implement it, and most importantly, we will evaluate the results and share learning across our partners and disseminate these findings so that other people can also learn. Polling question number 3, back to Lisa.
Okay. Here we go. So the question is, where do you go for your community health data? And the choices are EMR, you use outside consultants, the CDC, your state and local health departments, or other online sources. And those would include things such as county health rankings, community commons, and the city health dashboard. So give you a few seconds more to register your answers. Okay. Seems all right. I'm going to close the poll and share the results. It seems that the majority of people use their state and local health departments at 40%, followed by 20% using the CDC, and then pretty evenly 13% for EMR, outside consultants, and other online sources. So.
Okay.
Yeah, that's kind of interesting. I guess if we're forcing people to make the choice of one or the other when it's actually all of the above would have been the answer for a lot of folks too as well. But it's interesting to find out what the primary source is. And again, not surprising, right, Rickie?
Yeah, I think we all rely on our health departments for much of this information. So, and often that depends on the health department, whether that's available at a state level, a county level, or actually census tract or smaller level. And one of the things we're going to talk about now is, so where can you find that data? So one of the things we're going to talk about is health information exchanges. I know they don't currently exist in all places, but you can think about one of the things you can use is, how do you use your own admissions and emergency department data? Can you identify how, people who are high utilizers? So in the case of the story we gave you, the person was considered a high utilizer because of asthma. Can we identify conditions that are ambulatory care sensitive that really shouldn't be happening? And then what do we do about them? So health information exchanges are a really important source of information. And I can tell you, in Philadelphia, the major health systems are putting information into this neutral place, who then helps us share data across the hospital systems. And what's interesting about that, so let's say I identify somebody who's used the emergency department at Jefferson twice. That person isn't really a high utilizer, but that person also went to Penn, and they also went to Temple twice. All of a sudden, that person becomes a high utilizer. And those are the kinds of things that you can see that normally we wouldn't have access to. So we're looking at, how do you, as these become more and more embedded in cities and rural communities, how do we use health information exchanges for our needs assessment? We also have a variety of data sets. So CDC Wonder, this is national survey data. Back in when the ACA came in 2010, there was also an effort to make data available from the government and make it easier for people to be able to use that data. So some of the things I'm going to show you today are how easy it is actually to now access these data sets. So CDC Wonder has national survey data. They have tools about morbidity and mortality. Healthy People 2020 has county data, national goals and objectives. So if you want to set an objective, what is the national objective? What are we trying to reach as a nation? And they also include evidence-based practices. AHRQ is a great place to go to find out information about hospital costs and number of procedures that are being performed. And then you have other things like the Health Indicators Warehouse. So we will provide, you'll see at the end, web addresses for all of these things. There's also, so one of the issues in terms of particularly the health information exchanges that I didn't share is one of the big concerns is HIPAA. And there is a group called the Center for Healthcare Organizational and Innovation Research, better known as CHOIR. They have a toolkit that's actually designed to give advice on best practices for communities engaged in this type of cross-sector data sharing. So if you have concerns, you know, when you start thinking about how do we share the data, that would be a really useful tool for you. County health rankings and roadmaps. This is a great place. You can get data by county. You can compare your counties throughout the state. You can rank counties in the state. So I can tell you that, unfortunately, Philadelphia probably ranks last in the state. But I can compare myself to other counties too. And are we making progress? It also provides information on trends. So you can click on it. It'll tell you, is this a trend that we should be concerned about? Is this a good trend? Are we getting better? So it's very helpful in kind of looking at information over time. It provides comparison to the top US performers. So if we were the best performer in the United States, what might that look like, and what might our goal and objective be? And ultimately, you can also learn from others. What are others doing to address these issues? So you can get demographics, health outcomes, information about behaviors, clinical care, socioeconomic status, and physical environment. The Community Commons, I think, is one of the most useful tools that's available now. You can actually have a vulnerable population footprint. It'll map things out for you. Where are the populations that are most vulnerable, and for what are they vulnerable? They also have webinars and training on how to do CHNAs and mapping tools, which are really important. You can tailor reports, and we're going to show you later on how easy this is to use. But you can tailor your reports based on zip code, state, county, city, census tract, school district, legislative districts, or congressional districts. You can actually build custom reports with it. You can compare your city to the state in the United States. You can get breakdowns by ages, race, ethnicity. There's graphs, maps, trends. It really is a very, very useful data source. And they base it on a lot of the national surveys, such as the ACS and BRIFIS. So this is just an example of a map, and it basically is showing you population below the poverty level by CCTA, and what you see basically is most of Philadelphia is really poor. Over 20% of almost every area in Philadelphia is considered poor. And that's not a surprise, given that Philadelphia is the poorest large city in the country. Most recently, some of you may have heard about the 500 cities. And this now is called the City Health Dashboard. And you can actually go on and get information down to a census tract level. It's built, they use an algorithm that allows you, based on census tract and a variety of demographic data, to compute or to understand what this might be at a census tract level. So they use national surveys for this, and it's really good for planning, but you probably shouldn't use it for evaluating your efforts, okay? But it's a wonderful planning tool. Another tool is, it's called the CNI, and it is a community need index. And the interesting thing about this is it allows you to compare social determinants of health and get a single index for your various areas, particularly at a zip code area. It combines multiple social indicators such as poverty, education into this single index. It gives you a score of 1 to 5. Higher score equals higher need. And what's also telling is the higher need is also more likely to use your emergency department or your admission. So it gives you a sense of where might we want to put our efforts? Where do we need to be concerned? Policy Map also is a huge data source. Social determinants of health, community conditions, that you can do maps with assets and resources. Schools, hospitals, FQHCs can actually be put right on the map so you can see what those assets are. again, uses national data. They even have access to things like the SNAP data and supermarket access, and county level data is what you will get it at. But you can also get state, MSAs, zip code, congressional districts. And again, it's a wonderful source, particularly of demographic data, although they do have health data as well. Okay, best practice interventions. These are basically, you know, we don't want to reinvent everything. So where do you find these best practice interventions? And I provided you with links to websites where these exist. There are others also, if you're interested in cancer outcomes, RTIPS is another one that you might want to use. But it's always good to start with what works and what others have tried, and then tailor it to your own community as needed, and get input from your partners, your stakeholders. The community guide to preventive services. This is like really similar to the clinical, you know, guidelines that you would use for clinical care, only this is really what are those preventive services that we should be considering at a population level. Which program and policy interventions are effective? Are there effective interventions that are right for my community? And what do we need to think about cost and return on investment? The next one is, again, the community commons. I put this back in here so that you can see not only will the community commons give you what the key action indicators might be, but you can also look at what interventions might I want to do at a community level, and what interventions might I want to consider in healthcare action within your hospital or your primary care setting. So it's a really nice way to break it out and make it easier to find these interventions. Finally, the CDC Community Health Improvement Navigator. So here you can find out how to build collaborative approaches to doing interventions, but you can also find what interventions have worked best and have greatest impact on well-being. So that kind of, I think that's right. No, we keep going, sorry. This next tool is actually, I think, really cool. It's brand new. I haven't had a lot of opportunity to use it, but what it does is it helps you prioritize interventions. So what's the return on investment going to be? How does this intervention compare to another intervention that I might choose? How does it impact prevention of disease? So I would think about it as, if I have limited resources, this tool can help me compare the impact of strategies. This is kind of the, if you don't want to go to all that trouble, you can look at this and say, we know that these have worked, and it's just a quick health impact in 5 years. It's one of the CDC sites that you can go to. So Drew talked about the health impact pyramid. And one of the major things we want to do is focus on policy and systems changes. So these are sites where you can find out what are other people doing in terms of policy and system changes that appear to be working. So everything from environment to food to the county health rankings, you know, what might we want to put in? So I can tell you in Philadelphia, we have done trans fat, you know, and it seems to be really working. We've done menu labeling, and people actually use the calorie counts now to make decisions about what they should be eating. And most recently, we have instituted a sugar beverage tax, which I think is a really unique way. Initially, when they tried to pass it, they linked it to being obese, did not get passed, and people were not particularly happy with that approach. But what they've linked it to now is the money that is generated by taxing sugar beverages is going to improve our libraries and our recreation centers. So it's a nice way to sort of combine, you know, how do we address obesity? Well, we tax here and we put the money into places where we can improve social determinants of health and access. The Commonwealth Fund has put together a calculator that's designed to assist community-based organizations and medical partners in creating mutually advantageous financial arrangements for funding the delivery of social services to high-need, high-cost populations. This is particularly good if you've got people with clinically complex conditions or cognitive or physical limitations. And it basically is a financial tool that will calculate return on investment from integrating social services with medical care. So we are back to our case study. And the one thing we want to say now that we know that indeed asthma admissions are higher in the northern neighborhood of the city, is there more to this story? So as part of your needs assessment, we've talked about secondary data collection. Where do you find information? So they found that 837 children had more than 3 emergency departments in the past year, and it was across 5 health systems serving the same community. That would make this child a high utilizer for a condition that is primarily considered an ambulatory care sensitive condition or a failure to treat in primary care. And they found that 3 zip codes accounted for 64% of all the visits. So one of the things we're going to show you now is using how easy it is to use the community commons data. So the first thing we're going to do is build a report, and that you can customize it. You basically will enter your location. So if it's Philadelphia, and you'll say, I want to look at it by zip code. Make it bigger so you can see all the zip codes, and you literally just click on the zip codes that you are interested in. You tell it to view the report, and up comes the report for those 3 zip codes, and it will also do a comparison for you compared to Philadelphia. That's how easy it is to use this tool. It's literally clicking. You can also draw it if you want, and again, this is available in planning districts and congressional districts, so you can use it in a variety of ways. So one of the things you're seeing here is the ozone layer levels, rather, in Philadelphia are higher than we would want in these 3 zip codes. So, secondary data. What do we know? We know that the asthma hospitalization rate is 1,400 per 100,000 children, and that children under the age of 8, there's approximately 10,000 ER visits annually for asthma. Community Commons is telling us that we have adequate primary care. It's not really an issue of access to primary care physicians. They're also telling us that the ozone in these 3 zip codes is higher than we're going to find at the county or the state level. And then the city of Philadelphia, the health department, which most of you said, that's where you go for your data, is telling us that we have almost 1 in 5, more than 1 in 5 children in Philadelphia have asthma compared to 1 in 10 in Pennsylvania. A lot of these children are living below poverty. We have a pretty high level of exposure to secondhand smoke. Importantly, we have a lot of homes in Philadelphia that have leaky roofs, and 39% of asthma in children is due to housing factors. And asthma has also been linked to obesity. Philadelphia has high childhood obesity rates and low access to healthy, affordable food. So, what else do we need to know? It's really nice to have all this secondary data, but we also need to collect primary data. And one of the things you can get this through surveys, focus groups, or key informant interviews. So these are the kinds of things that people say. What percentage of people say, if you were to do a survey, say that their landlord won't fix the roof, or they're not using integrated pest management, which we know is linked to asthma. What percentage of people say they skip their medicine due to cost? What are the barriers to care? Can I miss work? Can I miss school to go get care? Is there access in the evenings and on weekends when I might need it? I can't afford to fix my roof. This is what you might hear in a focus group. I don't spend much time outside because the air quality is so bad. Or, you know what? And this was just true of Philadelphia. They did a huge report, and that our schools are in disrepair. There's mold, there are pests that have really increased asthma rates. And what are we going to do about it? And then at the individual level, do people know how to use their inhaler? Do they understand triggers and how to keep their home in a way to limit those triggers? Can they afford copays? Absenteeism and presentism, which means if you go to work, are you actually getting the work done while you're there because your mind is elsewhere or you're not feeling well? Truancy is a huge issue due to asthma, at least in Philadelphia. And then what we're finding, unfortunately, is your immigration status is really preventing people from coming and using some of the free services. And I can tell you that when we do blood pressures in the community, people are coming in and because we have ongoing blood pressures where you come back and they're giving us a different name each time. And that indicates that there's some fear that we might be using their name given the current political environment. So again, what are these evidence-based practices? So I went on and I only looked for those scientific practices, and you will, when you go on to look at evidence-based practices, you will be able to see that there's different levels of evidence. So these are the ones that came up in terms of science. Individual kinds of things. You know, are we helping just with knowledge and tobacco cessation and making referrals? Tobacco quit lines, telemedicine. Do we have chronic disease management programs? Healthy home environment assessments. You know, do we train volunteers? These are all kinds of things that you can do at an individual and interpersonal level. These professionals could go in and help people understand what their home health risks are. And are we following the National Asthma and Education and Prevention programs? At a community and systems, medical legal partnerships. So you say your landlord won't fix your roof. Medical legal partnerships can help write that letter to that landlord that says, you know what, you have to fix the roof. And what we've seen over time, I help evaluate these, is that it's amazing how that letter from the attorney makes a change. In Philly, we have a Healthy Row House initiative, which basically is low-cost loans to people at a low interest rate that allows them to get $15,000 to $25,000 to fix their roofs and stay in their home and not have these homes become even more disrepair. And that's really important because we have so many people, we have a lack of affordable homes in Philadelphia. Carpool and rideshare, improving air quality. Tiered drug formularies, you know, is there a way to make drugs less expensive for people? And then getting to policy, okay? Some hospitals have really been looking at making sure that all their vehicles or cities have clean air technology, okay? And are schools using pest management? And is it being used, integrated pest management, is that being used in low-income housing? Smoke-free policies in indoor areas, and tobacco taxes is a major way that we can reduce smoking. So these are all kinds of evidence-based practices that if you, based on what you've just seen in terms of asthma in our community, that you might consider using. And finally, we need to evaluate. And one of the things you have to consider is a process evaluation. And that really gets to how's this coalition building thing going? And, you know, are people making connections? Is the structure working? Are we communicating well? Are we being able to mobilize our resources and bring in new resources? Are we sharing information as part of the collaboration? So those are the kinds of things that we want to understand. And we know that in order to do this and be effective, that coalition has to be around for a long time. We're not going to fix this in 2 years or 3 years. It took us a long time to get here. It's going to take us quite a while to get out. And that's one of the, I think one of the challenges is that everybody wants a quick fix. And these things are going to take time. So we need to think about how do we build logic models that measure process, that measure short-term low-hanging fruit that we can measure, and how do we keep our coalitions or going long enough to get the job done. It's also difficult when you think about impact. Is it what we did, or was it the fact that somebody put a policy into effect and that also created an opportunity. So I think measuring these gets a little complicated, and you can always look at when did that come into effect and that new policy, and how did that also integrate with our evaluation. And then sometimes it's just hard to link the benefits directly to the initiative, and we need to think about how we do that. And ultimately, I think what's really going to drive this is if we can show return on investment. So, for example, there's Gunderson is a health system in Wisconsin, and they really put effort into clean air. That's where they really went in. So they put things in like wind turbines and to create clean energy. Not only did the air quality get better, people were breathing better, they controlled rising energy costs, but the system itself saved $3 million in being able to focus efforts just on improving clean air. So, how do we invest in workforce development? And can we coach our employees so that they manage to stay employed through that first year? And give them fair wages that they can live by. So these are all kinds of things that we can think about. Pipeline programs. So questions?
So, yep, let's hand it back to Tara, who is going to be leading our Q&A. And while you're coming on, Tara, I just want to tell everyone there was a really great article in the Atlantic magazine yesterday about Baltimore specifically, and telling the story of one woman and her health challenges, but really discussed the broad range of determinants of health, including adverse childhood experiences, environmental exposures, and all these things that were actually a headwind for her trying to achieve a better state of health. And so I would highly recommend that article to anyone on the call today, because there really is a chance to try to explain to folks how these things connect. And that article does an excellent job of doing so, and I plan on using it in my coursework going forward.
Right. Another article that I like to put out there also is by Robin Hack from the Center for Community Investment. And it's called Improving Community Health by Strengthening Community Investment, Roles for Hospitals and Health Systems. And it really goes very nicely through what others are doing across the country in terms of investment in housing and workforce and small businesses and minority-owned businesses, and thinking about how does investment in there also impact social determinants of health, which are then going to impact in improving the health of the community.
Right, and I believe we're going to put all this together in a document that will be distributed after the call, some of these references that we made today. Tara, are you with us?
Yes, I am. I'm here. First and foremost, thank you, Drew and Rickie, for such a comprehensive, thoughtful, and engaging presentation. We are going to be sending out a reference list that you have graciously put together for us, so we'll be sending that out in a follow-up email. We did have a few questions come in. So the first question, can hospitals combine efforts to conduct a community health needs assessment?
In other words, are they allowed to work together as opposed to producing their own community health needs assessment?
Yeah.
That's perfect. Yeah.
The answer to that question is yes, and the government is actually really encouraging hospitals to do that. So I can tell you that in Philadelphia, the Hospital Association of Pennsylvania, along with HHS Region 3, got together after our last community health needs assessment and said, okay, guys, we really want you to do this together next time. And oh, by the way, we also want you to get together and look at your community health implementation plans and see if there isn't something that all of you could work on together. And we helped fund a group called an organization called Healthcare Improvement Foundation, and put together a coalition called COACH. And basically what we came up with is several things. We are working on food security across all our systems and integrating food security screening into various models and treating it as a learning community where we're doing it in different ways and sharing information across about what works. We are centralizing our resources in Philadelphia. One of the big things you would hear in the community is we don't know where to find these resources. So how do we integrate, have one place to go to for all these health and social resources, How is it linked to our electronic health records? And then is there a public-facing spot where people can go and get these information on their own, and who keeps it up to date? So the answer to that question is absolutely, not only doing the needs assessment, but also the implementation plans.
And if the hospitals in Philadelphia can work together, as competitive as they are, I think this can happen anywhere. Anyone knows the Philadelphia market's quite competitive between the various health systems.
Terrific. So I just got a comment in and a question, and it says, a lot of great info. Can you provide access to this webinar for later viewing? I do want to say yes. Yes, we will. In the follow-up email that will also include the reference list, we'll have a link to this webinar. Lots of great information in it. I did have another question that has come in. Hospitals can't fix some health issues alone. Can you give an example of where a hospital helps to build a community coalition?
Well, I think hospitals need to become leaders within the community, and also recognize that sometimes they need to step back a little bit. It's so easy for the folks in the white coats to go into a community and tell everybody what's wrong with them, and be a bit, let's say, arrogant about that, and say, oh, you need to change your diet, you need to get your kids out more, you need to do more exercise, all these things, and yet not really appreciating the needs of the community. So hospitals have to have some humility, maybe the best way to put it. So the ones that are really smart are actually working very closely with community organizations. And I think that's beginning to happen here. And certainly Rickie's been involved in a number of different coalitions here in the community, in which Jefferson is really just a participant as opposed to the driving force and the lead agency. So that's not an easy thing for healthcare providers to be. Sometimes doctors especially want to be in charge of everything, but sometimes you got to learn to step back and let somebody else run the show for a while. Rickie?
Yeah, and actually having a neutral organization, which is why we chose Healthcare Improvement Foundation, because they work with all the hospitals. They were the natural group to bring us all together and provide sort of a neutral, and you know, they were in it just to help coordinate. You know, we didn't have to say, oh, Jefferson's in charge, or Penn's in charge, or Temple's in charge. So it's really important, I think, to have that neutral body. Other groups that are doing it, you might want to look at the Camden County
Coalition,
the Camden Coalition, and they've done a really nice job of bringing not just hospitals but also healthcare providers together, the FQHCs, and really working on interventions across Camden that are really making a difference. In addition, there's something called the Build Health Challenge, Invest Health, and Bridging for Health, and these are national initiatives. They're in 70 communities. These 70 communities are participating in partnerships between hospitals and other institutions to improve social determinants of health. So those are national efforts, and I believe they actually have funding attached to them, if that's helpful.
Great. Another question. So I'm quoting, I didn't hear anything about mental health, especially with teens and young adults. Was it left out of all the assessments?
I can tell you that mental health was forefront in my assessment. It's one of the major things that I heard in the community over and over and over again. Whether it was, we have an ACEs task force in Philadelphia. We have a large immigrant and refugee community, large homeless community, and we know that so much of that has mental health issues and behavioral health issues. I will say that since I did the last needs assessment, I think there's much more support for partnering on behavioral health issues than there was at the time. We do have, as part of COACH, a behavioral health task force, and we have been working on things like the city had an opiate task force to look at, drug use in Philadelphia, opiate use. We picked one thing that wasn't being addressed, and what we hope to achieve is integrating depression and anxiety screening for adolescents across the health system, so that we can do a better job identifying kids who might have issues that will then lead them to self-medicate and use drugs. So, we're trying to sort of fill in gaps that aren't being filled by others.
Rickie, let me follow up on that. Is it hard to get good data on mental health, behavioral health issues, as opposed to other health issues?
Not really. One of the places, at least for kids, you can go to the YRBS survey, Youth Behavioral Risk Survey. The BRIFIS, the Behavioral Risk Survey, which is for adults, has information about it. The Annie E. Casey data has information about behavioral health. And then most places have, providers of behavioral health, and it's another good place to look for data. Pennsylvania is a little different because behavioral health is totally separate from, other systems. But even so, we are coming together even more and more and looking at and sharing data.
Great. Okay, another question. Does a healthcare system have the capacity to be the backbone organization you referred to?
It does, and in many places it is the hospitals who are doing this. A good point is if you look at Chicago, they have multiple hospitals who have come together and are as backbone organizations and are doing this. Again, I think it's probably easier where there's fewer players. In the, Philadelphia, we definitely needed that neutral body, but I think in places where there's fewer players, a hospital could certainly serve as a backbone.
The hospital needs to make the decision to make this a priority, and specifically related to community health needs assessment. I used to say that if your hospital is using the marketing department to do the community health needs assessment, then it's just an exercise in marketing. If it's the IT folks who are doing the CHNA, then it's more pro forma, let's just get this done. If they hire an outside consultant. But if it's done at the C-suite level and it becomes a priority for the executives running the institution, then you've got a hospital that's fully committed to community health needs assessment and is willing to put the resources behind that. So I believe every CHNA should have the attention of the board, should have the attention of the C-suite folks when the hospital is conducting it, in order to really act on it. And it shouldn't be something that you do every 3 years, put up on the shelf, take it down 3 years later and blow the dust off and start again. It should be an ongoing activity, which means you got to put the resources into it.
But I think in many places, the hospitals are the ones who they employ a large number in the community. They have a lot of access to resources that others don't have, and can really bring skills to the needs assessment that may not be available depending on the community. So, and one thing we didn't say is, like by the way, the community health needs assessment has to be conducted by someone with public health experience. And sometimes health systems don't have that person, so they may have to bring in a consultant to do that.
Right.
So this is a comment, but there could be a question in this. I think we need to see scenarios of this type of effort at collaboration so we can see how these coalitions evolved and succeeded.
I think that's an excellent idea, and I certainly would welcome anyone who wants to reach out to us to tell us their story, how their system is dealing with this. I would love to be able to write up more cases that describe how institutions are identifying the issues, working through the barriers, and then achieving success in community health assessment. I think those stories are happening out there. We just need to document that and begin to share those experiences. I think one source that people could go to is IHI's 100 Million Healthier Lives, which is a program that is beginning to work around the country in different communities, trying to address, to assess and address health needs.
And then it looks like this may be the last question, but I welcome people to submit more. How do you convince the hospital's finance people to budget sufficient funds for community health?
Well, I'm hoping I made that case there, but if you're going to be doing value-based care and you're going to be held accountable to the outcomes of those patients, and using the example of JJ with asthma here, for the hospital especially, that hospital has had risks for the health of that child because most presumably self-funded. So by beginning to address the community determinants, all the factors that are influencing the health status of that child, you're going to have a better bottom line. So you spend a nickel to save a dollar. So if you're going to go to the CFO, the green-eyed safe folks who have to make the tough financial decisions, whose job is to make sure that institution is viable, you have to really look at that return on investment. So it's important to take a holistic view of all the different costs associated with adverse health events and begin to do something about that and make the investment. So it's really gathering the right numbers and enlisting the CFO as an ally in this effort, saying, well, how do we make an economic case for more investment in community health assessment?
So an example of that would be the Community Asthma Initiative at Boston Children's Hospital. And what they did is they had noticed that there was high utilization in their ED for asthma. They integrated things like home visits and providing tools, on how to clean your home and get rid of the triggers for asthma. And they had put in place policies that helped improve housing. And what they found is that they had an 80% reduction in the percentage of patients with asthma-related hospitalizations. They had a 58% reduction in the percentage of patients with ED visits, 45% reduction in the percentage of patients who missed schools, days of school, and a 53% reduction in percentage of patients with lost work days. Now, while that may not be enough, the return on investment for every dollar that they spent, the return was $1.46 to the health system. So I think what they did is they actually built in an evaluation that would help make the case, I think, to their financial people. And I think we need to do more of that, build in what is the return on investment. Think about what will this mean to the hospital in terms of readmission rates, which we all don't want within 30 days, right? So if we do this, how will it impact the business? And we need to think about that more.
Right. And as you begin to negotiate contracts with insurance, with payers, if you have a good understanding of what's driving health outcomes in your community, then you can build in more of a risk for yourself and a reward for taking on that risk. So it becomes more advantageous in those negotiations if you know that you can make a difference. So it's in your financial interest to understand all these health issues and then make it possible to take on greater and greater risk for those patients for greater reward.
Okay. Another question here. Those doing CHNA really need a workbook that incorporates all that you have covered, showing how and why to include social determinants of health.
Sounds like we have a writing opportunity here.
Again, the community toolkit, the community toolbox is one place to go for that information. Robert Wood Johnson on the Community Commons and has information about best practices and how to build coalitions. And so there are tools out there. I would be happy to do that.
Yeah, happy to help you with that. It is a complex process. It's certainly community dependent, what data is available in each community. It's also dealing with imagination. You have to imagine all the opportunities there are to address health needs. Too often we get stuck in our silos, in our own little world, and we don't think about the larger influences for health and also the advantages that are going to happen for the community. For instance, what about all the employers in the community? I mean, many communities have trouble, specifically the opiate issue, identifying potential employees who can pass a drug test. Well, they should be working with the hospital to provide the behavioral health care necessary to get people into treatment. And that's an opportunity for a healthcare institution to partner with non-traditional partners as a way to address those health issues, because it's costing employers a lot of money in terms of health costs and difficulty in identifying employees.
Yes, and there was a follow-up comment to the comment about the workbook. The attendee added, yes, and the workbook covers ROI to motivate management. So as you're thinking about the chapters in this workbook,
right,
a section on ROI would be great.
Absolutely. We're happy to do that for sure.
Okay. Okay, great. I think, let me just check, because with these conversations, keep getting more comments that are coming in, but I think that concludes our questions. So thank you, Drew and Rickie, for such a great presentation, and to the attendees for being a fantastic audience and posing wonderful questions.
It's
Excellent.
our pleasure. It was great to speak to you all, and happy to answer any questions. If you want to reach out to me or to Rickie, I'm sure we'll be happy to chat with you.
Yep.
Yes, and if you would like Rickie and Drew to come and give a similar presentation to your organization or something slightly different, please reach out to us, and we'd love to help. So thank you everyone, and have a terrific rest of the day.